called the National Health and Nutrition Survey, the NHANES survey. And there's been a series of such surveys. They're done about every 2 years. There they started in 1960. They've surveyed about 140,000 people. This is much more detailed because they record both health information and diet information. That's where the nutrition piece comes into play. And again, this is based on a census, based on trying to get a representative sample of the United States. Again, around the country, which are mobile data collection agencies where they bring you into these trailers and they put you on a treadmill and measure your cardiac function by using an EKG. They give you eye exams. They take some bloods from you and do lab tests. So this gives you a much richer piece of information. And again, this data is available to use. So what I would suggest is sometime going to the CDC website and just reading about these data sets to see if there's something that's been collected on a national or a state level that might be interesting for you to use as a research project. And here in Boston, a lot of people use these data for developing their research careers. And a lot of them use them as a first step for developing a research career in a particular area. I'll mention in our next homework assignment, I'm going to ask you to try to design a quick and somewhat maybe dirty study as to collect some pilot data to be used as part of a grant proposal for a later, more detailed, more expensive study. And any way you can answer a question quickly as a first phase might give you information to improve the next study you do. So using these existing data might be a way to start a research career, and I just throw that out as an option for considering. But let's switch gears now, and I'm going to ask Marjorie to speak in a few minutes about cohort studies, next of our observation studies. And in many ways, this is the natural epidemiologic study. A cohort study, basically what it involves is we enroll people who are at risk of developing disease. So if I want to measure whether acculturation increases the risk of developing diabetes, and I'm Kiabe doing that study, when I'm knocking on doors, the first thing I'd be asking these people is, have you ever been diagnosed with diabetes? If the answer is yes, that person's no longer at risk for developing diabetes. They already have it. So I'd say, thank you very much, sir. Thank you very much, madam, for your time, but I don't need you in my study because I want to look at risk factors for developing diabetes, and that's what a cohort study is doing. It's measuring incidence. So I measure people who are at risk for developing an outcome. They don't already have it. I follow those people over time, 5 years, 10 years, to see who develops diabetes, to see if the incidence of developing diabetes is more common among the group that claim to be of the traditional mode versus the assimilated mode or the other two modes. So basically, that's the big picture of a cohort study. And to describe it, let's think about one of the studies that we talked about last week. One of you sent in this little description to Erin when I asked you to think of how you design a study to measure the association between a diet that's heavy in SPAN and your risk of developing certain outcomes. And this was one of the studies that was proposed. It was study design number 2 in last week's slide. Basically, what it was using was data from a insurance or a medical claims organization, the Hawaii Medical Service Association, the HMSA, which I'm not familiar with. Maybe someone can tell us something about it. Marjorie's going to be talking in a few minutes, so maybe she or Piave or Erin can tell me more about it. But my guess is it's similar to the insurance that I have here in Massachusetts, Blue Cross or Blue Shield. So it would have names of individuals, some information about them in terms of demographics, their date of birth, their sex. But every time I go to see a doctor, or every time I go to a hospital, information would be recorded that's connected to a payment claim. Because if I went to a doctor's office, there'd be a claim submitted probably to this organization that would say that I had that visit, and chances are there'd be a code recorded for what diagnosis was made at that visit. And the same thing for hospital patients. So what you're able to do is by using these insurance data to basically get an idea of who's been diagnosed. diabetes, who's been diagnosed with other diseases, cardiovascular diseases. So this design was said, let's enroll 1,000 people. Let's give them a survey to see about what their dietary habits are. How often do you eat spam? And then we'll use the claims data to see if any of these people in the future would be diagnosed with diabetes, would be diagnosed with hypertension, diagnosed with cardiovascular disease, any condition that would be linked to a medical claim. So let's think about that study for a minute. And I put it under the heading of a prospective cohort study. I'll talk about prospective in a minute. Being what we would do today is we'd send a survey out to 1,000 members of this organization. We'd ask them about their spam consumption. How we would do that, we'd have to think about it. Would we say, in the last 2 weeks, how often did you open a can of spam? Or what did you eat last night? Or how often do you eat food that contains spam? So I'd be able to classify people roughly as heavy spam consumption eaters or no spam at all. I'd be then following these people into the future. See who of them develop diabetes, see who of them develop cardiovascular disease, not by sending them a questionnaire, but by using the data from this insurance database, the HMSA, I think it was referred to in this particular situation. So that's the basic design of a prospective cohort study. You enroll people who don't have an outcome, they're at risk of developing an outcome, so you exclude anybody who's already been diagnosed with diabetes or cardiovascular disease, either by looking at their medical records, and if there's nothing in their claims data set that said they were ever diagnosed with those conditions, then they would be candidates for your study. On the other hand, if their claim said they were diagnosed last year with diabetes, you would not want those people on the study. They're not at risk of developing diabetes. You then follow those people in the future and record who develops diabetes, who develops cardiovascular disease, and does not. That's the basic of a prospective cohort study. Let me ask you some questions about that. The first two questions deal with the enrollment or the selection of people. The developer of this design said, let's enroll 1,000 people. I don't know whether 1,000 people is enough to enroll in such a study, because the first two bullets influence the question of what sort of things are you thinking of when you're trying to decide who you want to enroll in this study. The next question asks, what other information would you gather on this survey besides spam consumption? The next question is a more general question. What's the advantages and disadvantages of using claims data like these? Answer this question in terms of following people over time and recording outcomes. And then finally, is generalizability a concern? Generalizability means that you might have a great study that describes the association between spam and risk of developing diabetes in these people, but they might not be generalized to other people. So someone mentioned that the HMSA is basically a monopoly HMO and a PPO in Hawaii. That's actually good news for an epidemiologist. Because if it wasn't a monopoly, if this was a certain type of person, maybe highly educated, maybe fairly high in social economic status that could afford to be in this particular program, then the results I get from this study might be very generalizable to highly educated, very high in the social economic scale type of individuals, but maybe not generalizable to other types of people, because maybe I wouldn't have anyone in my study who was not highly educated, who was not of a high socioeconomic status. So generalizability is a concern, but it's a secondary concern. The first challenge is to have a valid result, a result that's valid for the type of people in this study. You can't get that. You have a biased study or a confounded study, then generalizability becomes a moot issue. It's something that we don't even worry about, because we know the results from our study are wrong, so therefore how can they be generalizable? So the last bullet is important, but not as important as the topics we'll be talking about in the next few weeks, namely bias, confounding, and what have you. But let's go back to these first four questions in terms of the selection of people, in terms of the other information you would gather, and in terms of